Thank you for your good humor.
Thank you, Jamila, for all of your work.
It's live streaming now. Turns out it was a glitch in Firefox.
And Nu, I think my question is answered. I think we all have the same understanding. I just wanted to make sure that I was understanding it right.
Let me unmute myself. No problem, Sandy. Thanks everyone for just rolling with it. I appreciate that so much. And thank you, Jamila, for all your work that you're doing. This is only our first glitch, so you're good to go, lady. So why don't we regroup a second? And I want to pause. I want to also open up the floor for Rachel to kind of go over what OHA we took the recommendations, she took the recommendations back to OHA, and they've started some work on looking at what the recommendations actually entail and things like that. And so I'm going to pause here. I know that we kind of jumped in with some talk already, but I think some of the things that she has to share will also help guide us to continue the discussion that we're going to have today. So if Rachel.
Excuse me, this is Elizabeth. Can you turn on the captioning, please?
Did you grab that, Jamila? Super. Thank you, Elizabeth. And thank you, Elizabeth. If folks don't know Elizabeth, she is our closed captioner for the last several meetings. So thank you. We have her and then one of our Spanish language closed captioners. Thank you to all of you who do that work behind the scenes for us. Thank you. Rachel?
Yeah, thank you. It's a pleasure. So what we did after the last meeting and the phenomenal recommendations that you all made was go back and really start to begin it in operational analysis, and as someone mentioned, a legal analysis. And the goal is really how might we implement these recommendations and what are some various avenues to do that. And so I'll largely talk about some of the things that we discussed, and then I know that there's a presentation and that we'll have more discussion as well. In terms of understanding a legal analysis, we ultimately, want to see how we can go about doing things in a way that, obviously it's like many of our policy recommendations. Anytime we're working with any sort of policy recommendations, we want to do that analysis with our legal team to make sure that we are following applicable rules and ultimately having those considerations. So we've had that analysis underway. And the other thing is that many of the recommendations, which I really appreciated about the conversation that you all had, is they're overlapping. And so in thinking about, take something like multi-generational homes, right? There's multiple different ways that you could implement a recommendation like that. And then we're wanting to also do an equity analysis. Like, we ultimately don't want to make this onerous for people. We don't want folks to have to, and these are values that have been embedded in our vaccine rollout process the whole time. We're not interested in having folks come through or take an underlying health condition, bringing, medical records or bills or any of those sort of things. So these are the types of considerations and thinking, how might we actually implement some of these recommendations in a way that is, legal, is the easiest for communities, the easiest for providers who are implementing. If we don't want folks at a line to be trying to determine what someone's race or ethnicity is, or some of those things. So there's a couple of general things I think that came out. One of them is the potential of looking at dividing into, I shouldn't say dividing, looking at something like census tracts and trying to understand, we can talk about this more or bring it for a Tuesday if folks are interested in this sort of thing. But one of the tools that some folks have used, and I know that has been used also in Multnomah County, is looking at vulnerability indexes. So there's a way that data can be loaded into, this is my simplified lay version. Dr. Duldalau, you can you can break it down later, but is a mapping, and you can overlay a bunch of different things. You can look at what is the demographic population in that census tract, and you could do that by pocket large. We could look at Pacific Islanders. We could break it down into different things. There's a way to look at what is the populations, incarcerated populations. What are the underlying comorbidities or health conditions of that neighborhood? What are the occupational risks generally of that neighborhood. So there's a lot of the different things that you all mentioned that we can look at in a social vulnerability index. So some of our colleagues in program design and evaluation services have been working on an Oregon-specific, COVID-specific social vulnerability index. I don't love the word social vulnerability index, but the idea is that you can look at neighborhoods and start to see where different neighborhoods have risk based on comorbidities, like you asked for, based on BIPOC status, based on frontline workers, based on underlying health conditions. So we took an initial look at that to see what would pan out. From my perspective, one of the things that's beneficial about an approach like that, and it also has drawbacks, clearly, is that something like it gets beyond an individual perspective to more of a community perspective. So if we wanted to capture something like multi-generational households, you could get households in a view like that in a way that would be harder if we were just asking an individual to come in and prove or attest or what have you to how they fit into any demographic. The other potential way I think that we could look at this and have a conversation is within each of the categories that were listed out. Let's whatever one, underlying health conditions, or adults in custody, and within those there could be a conversation of prioritizing. And my hope would be that within that, there's an equity analysis conversation within each of those things. So if we were talking about frontline workers, for example, that this committee would be paying attention to, okay, well, how do we underlay the frontline workers who maybe have high COVID-19 case rates, and that within each of those, that there's an equity analysis that could be done, and that some sort of sequencing could be done. So those are a couple, I would say 3 of the types of considerations that we thought were potential ways to take these recommendations and operationalize them. So just to summarize, more of a census tract. We couldn't quite get to zip code, but that sort of analysis would allow us to layer multiple recommendations on and prioritize in that way with communities and get to a bit of a broader swath of people, but layering those multiple recommendations that you made. Or we could look at the recommendations in and of themselves based on their equity analysis and based on data and say, we think we should move in this order. I will say one other thing, that we also looked at is in terms of migrant and seasonal farm workers, there's there's a calendar-based consideration here in terms of when the growing season is. So I think that there are also strategies that we could look at operationalizing that are really based on, for this particular type of work, timing is everything. And that's why we may need to have a strategy that is culturally specific in this way. And that could include migrant seasonal farm workers and food production. So I guess those are 4 potential different ways that we could move forward, or 3 with all of them having legality analysis with them.
What folks, do you have questions for Rachel? Marin and then George.
Hi, Rachel. And I guess from a legal standpoint, again, I'm not an attorney, but to me, whatever we do is driven by data. So in terms of, we're not picking, for example, the BIPOC communities that we mentioned, Latino, Pacific Islander, or other ethnic groups because they're ethnic or because they're Black or Latino, because they've been impacted so severely by COVID that we need to focus on these communities based on the data that we have statewide and the numbers. I think I remember you mentioned 47% of the Latino population is impacted by COVID statewide. So to me, from a legal standpoint, it's all driven by data, nothing in terms of race or ethnicity. So for me, from a legal standpoint, I think we can make that argument that it's all data driven. Again, that's my perspective.
George?
Yeah, just a quick question. I'm not sure that there's a direct answer. But since we only currently have use authorizations for two-dose vaccines, if we're talking about migrant populations, we'll have to think about and how we would engineer that people would get their second dose somewhere else, and how the enrollment and whatnot, because some of the very highest risk outbreaks have been migrant populations working in fish processing, working up and down the West Coast, and then various types of seasonal crops. And of course, some of the big outbreaks in Eastern Oregon have been related to those, as well as more routine things like the people that reside largely in Ontario that work in the potato sorting and whatnot in West Idaho. But it seems like there's two options. One of them is to engineer that. And the other is to hope, but I don't think it's going to happen in the next 2 months, for one of the single dose vaccines to be used. And what we may need to do is engineer that until one of the approved single dose that has high efficacy ones is approved, and then be prepared to switch to that. Thank you.
Yeah.
This must say, I'm sorry.
Oh, I'm sorry. I'll go ahead, and then I'll be.
Well, thank you very much. I definitely would, when you say census, are you talking about US Census, or are you talking about the recent census of the data of the infection rates? I want a clarification on that.
So there's Muse is asking about the clarification of whether we're using census data.
This is Margaret Braun from Program Design and Evaluation Services. It's the U.S. Census tracts that are, let's see, the data are based on the ACS, the American Community Survey 5-year estimate that was published in 2018.
Okay, just wanted to add that one because I advocate for the Eastern African and specifically Somali community, and the U.S. number of 1,200. It's the population is 10 times that, so it will be way off, and it doesn't count the secondary migration. A lot of families that moved out from another state. So if you go by that one, we're going to be way off. My recommendation, and definitely the data is the facts. You cannot argue with the data, infection rates in the community. So that's one way to go by if you don't want to mention race, ethnicity. But also another suggestion that I have also that is go by zip codes as well. Also, this zip code that has higher infection, maybe we can prioritize, and that would be a way to kind of move away from issue that might arise in legality on the race as well. So that's my recommendation. But definitely, it should not be ignored data. But census is not gonna help this community that I've been serving them for the last 20 years.
Thank you, Muse.
I just wanted to clarify. So Muse, it's not the actual census numbers. We're not using census numbers to estimate populations. It's more the tract by which the census targets geographically. So they go geographically in predefined geographic areas that are called census tracts, which are slightly broader than zip codes. They usually incorporate multiple zip codes in one census tract, but that's the level at which the social vulnerability index has been calculated. So it's not really the census numbers as much as the way in which the census does their survey, which goes by tract. So it's a way of geographically targeting populations. That way you could incorporate populations that might be highly impacted that happen to live in certain census tracts geographically. Does that make sense?
Yeah, that makes sense because I know that as of July, almost 7 to 8% of the cases in Multnomah County were two communities from East Africa, mainly Somali and Congolese. Both Black communities, which is kind of in line with the general population of infection rate nationally. So that's a fact that you cannot ignore as actual data. And that's what I would like to go without really naming ethnic or race at all. Thank you.
Okay, thank you, Muse. I'm going to have Deborah go and then Maria go. I want to address a couple things in the chat real quick that I've seen. So I don't want the chat to get away from me today. Margaret put in the chat the link to the COVID-19 Community Vulnerability Index that Rachel had mentioned. I also want to, let me scroll down a little bit here. A comment from Kristen that I'm all for moving forward with data-driven as our focus. And then Deborah Whitefoot says, does anyone here have data on the 9 tribes in Oregon? I've been listening very patiently and have not heard any discussion on the very vulnerable population of tribes. Warm Spring is losing elderlies weekly. These are very valuable knowledge keepers and language speakers. So I'm not sure within the presentation today if we'll have more specific information on our tribes or not. Deborah, does anybody at OHA want to speak to that? And then after that, I'm going to have Maria go, and then we'll come back to the chat.
We have not presented that data yet. We had some general information on tribes and their allocation coming from a different pathway. That's not the state allocation in the Tuesday session, but that's definitely data we can bring back from our tribal partners and the folks with the working with the numbers and operations around this work as to which are the tribes most highly impacted.
Shamia, this is Nanette speaking, when you're referring to the data for the tribal community, since they're identified as sovereign nations, is the allocation that was identified at the federal level going to be distributed to the states also include the distribution to our recognized tribal communities?
I think Rachel can clarify, but my understanding is that it's a separate allocation scheme. So they're not reflected in Oregon's numbers.
That was what I was led to believe as well. So I just wanted to confirm that, and that there is a different track, so to speak, as to how the recognized tribes are being handled as it pertains to the Indian health organizations, if I'm not mistaken.
I'm not sure the answer to that question. I know there was a slide that mentioned, and I apologize, I'm not the expert on the tribal allocation or the data around it, but I believe every tribe is actually allowed to determine how they want their allocation. Either they want it through the IHS program or the state program. That's what I remember from the slide, but I would have to take that question back to the people who know better. Rachel?
Yeah, I think that's right. So there is a couple of different ways that our tribes can have gotten vaccine, either which was the choice of the tribes, either directly from the federal government or through the state, which we allocated. I think in terms of sovereignty, the important thing is that tribes determine how they are going to allocate. So our conversation here, for example, in terms of how we prioritize, that's not going to apply to the tribes. Tribes are determining, how and what order and who they're going to be vaccinating as sovereign nations.
I would just like to say a few words. I appreciate the recognition of this tribal sovereignty. I do appreciate that. The group of people that I'm advocating for live along the Columbia River, which is 2 to 3 hours from any tribal reservation. And I know that we did receive an allocation for the tribal people living at the Columbia River, which would include tribal people from Idaho, Oregon, and Washington, the 4 Columbia River Treaty Tribes. And so these are a group of people that are silent and they're unseen. And I'm hoping to make that not the case anymore. And I know the Native Americans are always kind of left out. We're not heard, we're left out, we're kind of a population that's unseen. But I hope to maybe have an educational moment of land acknowledgement of the land that you're all sitting on today did belong to Native Americans before everyone came here. So I hope to change that, because the problems are systemic that we face, they're in the system. And so I'm advocating for the people that live along the Columbia River to receive more vaccinations. And I just wanted to say that, and I don't want to take up too much of your time. So that's all I wanted to say. Thanks.
Thank you, Deborah. I have a couple more comments in the chat, and then if we can pause and perhaps have our presentation on the data. Would that help folks kind of get some more information? Does that sound okay with folks?
Yeah. I just wanted to follow up.
Oh, yes, please, Maria.
The migrant seasonal farm workers. I know that the migrants are migrants and they migrate and they come and leave, but we have seasonal farm workers that are staying year long here in Oregon, and we need to think of that. We Virginia Garcia Federal Qualified Health Centers, we did 1,000 tests for migrant farm workers and repeated the test within 2 weeks or 3 weeks. So I think that trying to wait for a one-dose vaccine is just a delay in that. I would like for that not to be for us not to recommend that, because I think if we can give them the one dose and they can get the second dose at their second clinic and we can work on that. But I think that they're here long enough to get their second dose.
I wholeheartedly agree. I was only mentioning that as a contingency if and when there's a single dose that become available. I think it would be irresponsible for us to delay using the current vaccines. And I'm sorry if that what I said was understood to convey that. Thank you.
Thank you, George. And that was based on the chat. So I'm going to scroll down a little bit and look at a couple of other pieces. Delisa said that we should also remember there are members of other tribes living here in Oregon that use the different Indian health centers. Are these members included in the data as well? Can anyone at OHA answer that?
I don't think we've presented any specific data around that topic, and I don't think any of the data that we're going to present today does include that. We can definitely incorporate that into a future session.
Okay, thank you, Shimi. Again, tribes from Sue, tribes had to choose one or the other of the vaccine sourcings, the state or IHS, Indian Health Services. Okay.
I know our tribe, the Siletz tribe, we tried to include those type of people that may be living here and don't belong to one of the Oregon tribes, but use tribal services. So we're personally offering vaccinations to other natives as well.
Thank you, Charity.
I think Zhenya had a question, and I think that wraps up the questions for now. Yeah.
Okay. Thank you. Zhenya?
Yes, I'll make it very brief, but I have 4 very quick points and I would like yes or no, or, no need to discuss. It's clean and clear. So we were told by the legal team that the self-identification as BIPOC cannot be used as a basis for priority similar to age. Is that a yes?
Can you say that one more time?
Self-identification as a member of the BIPOC community cannot be used as the basis for priority similar to how the age is currently being used.
I don't think, this is Rachel, I don't think it's a yes or no, and I would definitely be remiss to give a yes or no on a legal analysis answer. So let's get that one kind of written down, and then we can come back with kind of legal analysis and what's shareable.
Okay, so based on that, the second clarification is we are nonetheless leaning toward the understanding that a more fair or equitable way to do it would be to focus on targeting certain communities and addressing it through distribution and information. Is that accurate? Is that the direction we're going on right now?
I think they were suggestions. I'm not sure if we're really saying they're decisions quite yet.
Okay. And then my third clarification was that if we're going to go through the distribution channel in order to target these communities, it sounds like there are different ways to approach it. There is a potential for some census measure. We don't know how valid it is for us or for our communities. There's this other, so that this group, I think, can really help guide the knowledge of, whether census would adequately represent that, or if there's other knowledge such as the Columbia River populations, et cetera, that aren't potentially captured. So I think that's where our group can provide most value because we have the expertise. And my last comment I was going to say is with any prioritization, whether it's direct prioritization or by neighborhood, we should be aware that these vaccines expire very quickly. And already with current prioritizations, we're seeing situations where there are not enough people falling into the specific category showing up in time to get the vaccine. So doses could get wasted, and they already have. And so we just need to keep that in the back of our mind as we devise these prioritization strategies, that there should be a fallback strategy for And what if you have 20 doses now defrosted, unused, not enough people in the pocket where you went? How do we fill them? We need a plan B for that.
Thank you, Zhenya. I think that some of the pieces that will be offered as far as information from OHA today may help with some of the clarification of that. And then also being cognizant of the fact that this group can be really instrumental in sharing information to communities as well. And I think some of that we'll be discussing next week on our Tuesday meeting and perhaps even into the Thursday meeting. So with that,
No, I also have had my hand up and I wanted to make
sorry, I didn't recognize
Thank
that.
you.
My apologies.
Yeah, when we talk about prioritizing frontline workers, I absolutely agree that there's an opportunity to line that effort up with our effort to make sure that there is equity in the distribution of vaccine. We talk about agriculture workers, and I know Virginia Garcia has such phenomenal partnerships that we need to build on those with employers. And they're all over the state, food processing. But we also have to, I think, one point, we can't be too narrow about how we do it. So I was on the phone yesterday with a food processor in Southern Oregon. They employ 1,000 people, 75% of them are people of color. They're willing to work when vaccine is available to not only vaccinate their employees, but their employees' families and members of the community. So we can't let the perfect get in the way of the good. If we have the opportunity to reach a broader population, let's figure out how to do it, because our goal is to get shots in arms and to save lives. The second thing I would say is that we can't lose sight of critical functions that have a secondary impact. Food processing, we all agree, food is really important. We had a toilet paper shortage. We make toilet paper here in Oregon. So we have to be thoughtful about other critical functions, the people at the grocery stores, the people in the banks, because there's a lot of people in our state, low-income people, who don't do online banking. So we've got to make sure banks and credit unions, it's a big list. I talked the other day to some post-secondary educators. They're not in the first round. They want to get their people back in classrooms. If we look at who's dropping out of our post-secondary system, it's kids from marginalized communities that they're losing the most. So when we start looking at frontline workers, I think we have to be thoughtful and careful and not get so specific that we're inadvertently leaving off critical people and being too narrow in how it's applied.
Thank you, Sandy. I'm going to have Kelly go next. I apologize. I don't see the hand raising function for some reason. So if you would like to go next, please just go ahead and let me know in the chat that your hand is raised. I don't actually see the hand raising function. I'm not sure why, so I apologize. Kelly, please.
Great, thanks. Well, it's good to be with you all. Thank you for being here today. These are big conversations. I feel a lot of fear and some scarcity mindset and approaches in some of the sharing that I'm hearing today. And I really want to encourage us to stay in a positive mindset with a good heart and a good mind. And remembering that our communities have so much, we are self-determined. We know that we are in challenging times, and we're striving for thriving, right? We want thriving future generations. We know how to mobilize. We know how to pull our communities together and get them the resources. Once we have the capacity or the opportunity or the funding or the vaccines available to us, we know how to get that out to our communities. There's tons of evidence of it. We mobilize to take care of our communities. We pivot all the time in the face of racism and lasting impacts of colonization. We are here today because we are descendants of miracle survivors of genocide as Indigenous people. We have the strength to move forward. So I want to just center that. And I want to also uplift what Deborah is, what I hear from Deborah is that an additional focus in terms of our approach, building off of what Rachel offered to us, which was 4 or 5 points, starting with census tract, layering, mapping, understanding social vulnerability index, and then considering some prioritization. What I heard from Deborah, which I think is critical, especially as I'm noticing in the chat, people wanting to bring in land acknowledgement. And we do that because we bring in Indigenous people, the first peoples of these lands. And in doing that, we get to ask, where are those people? Where are the Indigenous people? And what I hear from Deborah, and I've heard from the beginning from Deborah, is that our equity must start with Indigenous people. Where are the Indigenous people in the equity frameworks? Not just tribal folks that are, but all Indigenous folks. Some of us are in urban settings. Some of us don't have those protections of our tribal governance here in an urban setting. Some of us are not even represented in the data. And some of our leadership say this is a form of contemporary genocide when we are not represented in the data, when we are not represented in the policies. So we have an opportunity to include another framing in our equity approach, which is starting with the people of these lands. And I just want to say thank you, Deborah, for your leadership, and I appreciate your guidance today. Thank you.
Thank you, Kelly and Deborah, for recentering us in a fashion that is honoring to this process. Thank you for that. Would folks like to, at this point, how would you like to move forward?
Can we move with a presentation? The data that.
Yeah.
Okay, well, sure. Thank you.
Okay. So we'll go ahead and switch to the presentation at this point. And I'll turn that over to Shimi. Following the presentation, I do want to acknowledge that we need to take a quick accommodations break after the presentation, and then we'll go into some time for questions.
So some of the data I'm going to present are high-level estimates for some of the populations that the group came up with as priority groups at the last session. Next slide, please. So this was the VAC proposed sequencing suggestion from the last session. Black, African American, Hispanic, Latino, Latinx, Indigenous, tribal, and urban-based natives and Pacific Islanders. In short, people experience the impacts of racism and health disparity on a daily basis and are currently experiencing the highest rates of COVID-19 in the state. Refugee populations, adults 16 to 64 with chronic conditions, with the understanding that adults over 65 have already been prioritized for the 1B, for one of the first 1B groups. Adults and youth eligible for vaccine who are in custody, and frontline workers, those who live in multi-generational homes, and low-income senior housing and other congregate senior housing, including people, because this is a group that has not been targeted within the federal allocation program. Next slide. Sorry, I'm having a delay. I think I don't see the slide up yet.
Jimmy, this is the slide confirming some of the next steps that OHA committed to taking last week.
Yeah, unfortunately, I don't see it yet. So until it comes, I can't really talk about it. I think it's just like a mild delay in my internet. So I'm just waiting for it to populate. It usually happens like in a couple extra seconds. Let me try what Jenny is saying, turn off and turn back on my video. I don't know if that really helps, but.
I also
There you
wonder
go.
if, I don't know if anyone else has a copy of this, Shimmy, and can drive the slides for you.
Yeah, no, I have it
From
now.
their
Yeah.
monitor.
So OHA follow-up items after last week's meeting included that OHA submitted a draft prioritization document to the Department of Justice for review, and that's what Rachel shared at the beginning of our session today as to some of those discussions that are currently happening. Next slide. Man, slow.
Shimmy, let me help you out a little bit. This is
Okay,
Dean.
yeah, if you can proceed while my computer is catching up, that'd be great.
We will tag team. So for this data, we use census data. This is the American Community Survey that goes out and asks additional questions beyond the every 10-year census that we can get a general picture of overall state, maybe not as much into individual groups. Behavioral risk factor surveillance survey is a telephone-based survey that is done by OHA in partnership with the Centers for Disease Control that asks people questions about their health, whether they've been diagnosed with certain conditions, how is their health and their access to care, and some other things. We reached out to our partners in the Department of Corrections to get information about adults in custody and youth in custody from the Oregon Youth Authority. Next slide.
Dean, could you talk about maybe
Yes.
some of the limitations of those data sets? I think that was one thing that you're.
Okay. Yeah. So for these data sets, the American Community Survey is done on a subset of people. We can't necessarily go in depth and get that down to some of the smaller subgroups within the population. Pacific Islanders, for example, with behavioral risk factor surveillance system under the usual conditions, we can't necessarily get down to that level. Never mind the fact that that Pacific Islander label encompasses many disparate groups that are very different and may answer differently. So we're trying some new methods to get data like that, but for these data sources, we rely on some broad community-based surveys that unfortunately we can't break down as much into smaller groups as we'd like based on race and ethnicity. And they don't have the real D components in them as federal partner surveys all the time. We can go to the next slide. People fit into multiple categories, and so depending on how they answered the questions or how their answer was recorded, it may not fully reflect, so some of the numbers may be misleading. We've had to estimate some of these numbers because we don't have good access to the broad universe, so we've tried to find the best data, the best partner to help us with that, but still do have some estimates. And how the vaccine comes in, we have to consider the operational impacts and our prioritization, how they work together so that we can get as much of the vaccine out as quickly as we can, but also make sure we're getting it to the people who may have the least access. And so those two things in mind as the operations comes up against prioritization. Next slide. So our current population here in Oregon is just over 4.2 million people. I believe this may be it, yep. And the breakdown by population group, this is from the American Community Survey from the census, shows that about a little over 500,000 individuals identify as Hispanic, about 75,000 individuals as Black, almost 37,000 as American Indian, Alaska Native, 15,000 Native Hawaiian, Pacific Islander, a large group of multiple races, 150,000 and 6,400 people had identified an other in the census data. For population estimate for chronic conditions, again, coming from our survey data, show that adults living with one or more chronic conditions is a group that includes almost 1.8 million people. Some of those individuals exist in the population 65 and older, as Shimi said, who will be vaccinated in an earlier piece. For adults in custody, our Department of Corrections staff reports that there are 13,145 adults in custody. And Oregon Youth Authority currently has 825 individuals, totaling just under 14,000. For low-income seniors, housing adults who are under 65, we estimate that there's about 12,500 individuals in Oregon. And the estimates that we have not yet captured is the refugee populations that are not already captured in some of the racial groups. So we have some information not on refugees, but on our Slavic immigrants in the chat. The number of people aged 16 to 18 with chronic conditions, as they would be prioritized along with adults with chronic conditions. Our frontline workers and those living in multi-generational households are a more difficult piece of data to get. These are the allocations of doses to date here in Oregon. The federal partners refer to them as prime and boost doses. Prime are first doses, with boost doses typically shipped in the weeks following to give people their second dose so that they are fully immunized. As you can see, vaccine began arriving in the middle of December. Initially, just Pfizer BioNTech vaccine, and then a week later, the Moderna vaccine was approved, and we received additional doses from there. We got a bump up in our doses that second week with the addition of the Moderna doses. Some of those were allocated to congregate skilled nursing facilities and other congregate facilities. The week of Christmas Eve, our vaccine doses did go down from the prior week. And then the prime doses, the first doses, remained relatively stable and do remain relatively stable going through January. We've started adding the New Year's Eve week the second doses of Pfizer BioNTech vaccines to give those individuals who've been vaccinated their second dose 21 days later. And the Moderna doses followed 2 weeks later because there's a 4-week interval there. So overall, we've had just over 610,000 doses of vaccine allocated through the week of January 21st. And Shimmy can step in if she ever wants to.
Yes.
We expect, go ahead.
Oh, so like Dean was saying, so there was a slight bump this past week just because we were exactly 4 weeks after the first Moderna prime allocation. So the 72,100 that came on the 20th of December was reflected in our 14th of January boost allocation. And then Zhenya is asking about if this is the predicted and anticipated number of allocations, and that's true. Next slide, please. So we anticipate getting about 25,350 of the Pfizer ongoing, as well as an equivalent number of the boost, and then 24,800 prime and boost for Moderna, or thereabouts, depending on what the prime doses were 3 or 4 weeks in advance of the week that would come up in the future. So about 50 to 60,000 prime doses per week. I think we have some additional questions that have accumulated in the chat.
Yes, Shimmy, there was a question. I think you've answered it specifically about the number of prime doses. Is it expected to continue at this rate indefinitely based on the current information?
Based on the current information, yes. There could be changes just with the recent change in administration, and the supply is anticipated to change based on what the federal government might do in terms of ramping up production.
And then, I would also say as we do more and more prime doses, that more and more of our allocation needs to be devoted to second doses. So if we were going to get the same amount over time, we would want to make sure that we have enough allocation for those second doses. So those prime doses may decrease to ensure that we would have enough for the second doses. With the huge caveat, like Dr. Sharif said, that all of this is based on federal allocations and what we're getting.
There's a question from Lori. Of the 600,000 doses, how many have been given or are sitting on the shelf? Do we know that?
I'm trying to pull up our vaccine dashboard.
While you're doing that, Shimi, I can say as of yesterday, there was over 225,000 doses. And I would also say that sometimes when we see an allocation number, that doesn't mean they're sitting on the shelf. So I just want to put that caveat to people, those that sometimes when you're looking at numbers, it's the doses that we've been allocated doesn't mean they're sitting on shelves. The other thing just in terms of that is that we have to maintain those second doses. So there may be allocations that people think are not used, but they have someone's name on them, so to speak. So they are being held for those. And I think we've been doing a much better job in getting the doses out per day. But I know that like I said yesterday, there was over 225,000 first and second doses that had been administered.
Yeah. Kelly in the chat says, in addition to racism, I recommend that we include anti-Indigenous or settler colonialism to acknowledge and be accountable in our approach to equity that brings in the determinants of health that are specifically experienced among Indigenous peoples within the U.S. nation state. Otherwise, land acknowledgement is performative. Thank you, Kelly. Zhenya, interesting. So second doses will be prioritized over prime, meaning the goal is to get every second dose. And I believe Rachel answered that.
I wanted to just follow up on the low-income housing.
Yes, please.
There is the federally subsidized low-income senior housing is part of the federal allocation, but there's a lot of seniors living together in congregate settings that are not licensed and covered under long-term care, that are not part of the HUD federally subsidized housing, that live together. So that recommendation was really dealing with seniors that are living in those environments. They're going to be covered by 1B in those populations, but if they're living in a setting that has under 65 for expediency and delivery, we'd like to see those people included in that.
So include those folks as part of the
as
recommendation.
a priority. If you're living in a congregate senior housing that's not part of the federal that's not included in 1A.
Yes.
That in 1B, if they are in a household or a congregate living setting with someone under the age of 65, that those individuals could also be vaccinated.
Okay. Thank you, Ruth.
I.e., I'm 65, I'm 70, and my husband is 62.
Okay. Thank you, Ruth. I'm going to go ahead and read a couple more from the chat, and I'd like us to take a quick 5-minute break to accommodate that important piece. And then I would ask that folks continue to put your questions in the chat, and then we'll just go down the list. And then I would like to give us opportunity to continue the discussion. We have a little less than an hour, so I want to make sure that we're kind of moving towards some idea of what the recommendations within the groups will be. Okay, so I'm going to take a couple more questions and then ask that we take a break.
It looks like we did answer Maria Laredo's
okay, thank you.
question, as well as Nanette's question. Have the doses been looked at by race or ethnicity? And Dr. Dildalau actually answered with the dashboard, which does break down current administration so far by ratio groups from the data captured from the alert database.
Okay.
And then Dr. Raphael has a question.
And what about Nanette's question? Query, what is the distribution to date for our BIPOC Oregonians?
Right, and that is answered by the data on the dashboard as well.
Great, thank you. Kalani, please, your question.
So, Dr. Seilinger, just kind of a back of the envelope calculation I had based off of the data you showed, it looks like the groups that we prioritize would be roughly about 1 million or so of the Oregon population. Am I close to that number? Because it looked like there were about 800,000, BIPOC just alone. and some of that's going to be kids under 16 who aren't going to get vaccinated. And then you had, I think like 13,000 in custody, and then the 70,000 Slavic folks. So it is about 1 million, the number that you showed?
That's probably fair. Dean, do you know the numbers of people over 65 in Oregon? I guess that's the one estimate we didn't show, and they're already kind of up next.
Right, and I don't have that breakdown right now, unfortunately, with being able to get those over 65 out. So that is probably a fairly good number as a starting point. I think it's ballpark area.
So that's about a
to that if I
quarter of
could.
the Oregon population then, right? Roughly.
Right.
So
Couple things
we
I-
have to,
Sorry, I just want to add a couple of things. One in this is that the underlying the comorbidities was about 1.7 million, if I remember right. So if you add that in there, it's many more than just the 1 million. And then to answer another question, I believe it's around 800,000 for the 65 and over population in Oregon.
yeah, I mean, we have to prioritize. I mean, otherwise there is no priority. And we have to think about what chronic conditions we're going to consider in this list. I mean, we have real work to do to prioritize this. Otherwise, we're not going to get any priority, really. So it's good to see those numbers in Oregon. So thanks for sharing that.
The other thing is also the chronic conditions pulled from the BRFSS might not reflect the chronic conditions for COVID-19 based on the CDC list. Yeah.
Right. Like, for example, overweight is roughly half of the population already, right? So we're going to have to think about what we consider chronic conditions that are specific to COVID and risk of hospitalization and mortality. Thank you.
Thank you, Kalani. I'm going to ask that we take a quick 5-minute break and then come back and regroup. Jamila or Kristen, can you pull up the slide that was part of the presentation that showed the proposed sequencing suggestions that the VAC came up with last week? It's, I believe, slide number 2. I just want everybody to kind of have a view of that, just so folks are reminded of that piece as we work through the sequencing piece.
Kristen, are you able to do that so I can pull up my stuff more quickly to do updated notes?
Sorry, can you repeat that?
Kristen, can you pull up that slide in the presentation from our health advisors that showed the list of who the VAC recommended last week? It's slide number 2 in the presentation of the PowerPoint.
And if the group is interested in making edits, Kristen, you can put yours down and I'll bring up my Word document.
Yeah, perfect, Kristen. Thank you. Okay, welcome back, everyone. I'm going to go ahead and get started again. Thank you for taking that quick bio break for everyone. I had the team pull up the proposed suggestions from last week's recommendations. Again, this is the group that we are just wanting to concentrate on, thinking about based on the numbers that were presented in the presentation. We know that, okay, number of doses and the number of people within these population groups, it doesn't match up. And so how are we going to move forward in thinking about what and who we want to move forward? And it looks like there's some chat in the chat function. So I want to review that real quick. Okay, where are we in the chat? I'm going to start with, it looks like Zhenya said 15 weeks, nearly 4 months only. Then we are going to the next group of sequencing. And if that's over 1 million, we really will have to decide how priority works. Marin says, sorry. I think we should start the priority of the people that are getting COVID-19 at the highest rates, which is based on data. I think also the committee should recommend that we start an aggressive outreach and marketing campaign that is culturally targeted at these groups. Safina, I agree with Marin. Lori, I totally agree with Marin. I feel like we're getting off track a bit. Zhenya, in my experience, limited, these populations are particularly reluctant. We need to start working on the hesitancy. I believe that's part of the campaign that Marin is suggesting. Sean, I do believe we need to make at least some priority grouping in order to have an effective deployment. However, the grouping must be broad enough to allow for the practical considerations of using every dose, which is a challenge. Thank you for that. Safina, we can do things in parallel, prioritize those most impacted and work on hesitancy. Yes, people within the groups should be offered opportunities first. Kristen, as we define groups, as we've defined groups, we've identified, I'd like to clarify on what BIPOC means, not the definition of the acronym or who is included, rather what that means in regards to prioritizing and what we are actually saying. For example, if we sequence BIPOC, if we sequence BIPOC, I'm losing my. For example, if we are sequencing BIPOC at the top of the list, proposing is the suggestion as proposed that a 20-year-old Pacific Islander have access to the vaccine sooner than a 64-year-old bus driver, grocery store worker. My apologies. Shimi, can you read the?
Yeah, I can read it. Yeah.
I can't find
it keeps moving, I guess, when a new
moves
chat
fast.
comes in.
Y'all are chatting fast on me today.
So is the suggestion
Please.
as proposed that a 20-year-old Pacific Islander have access to the vaccine sooner than a 64-year-old bus driver or grocery store worker, or whatever we define as a frontline worker? I know these answers don't exist yet, but these are questions I'm pondering as we acknowledge there are many more people than vaccines. Mose says data should be a priority, yes, on cultural specific targeting, vaccinating this group. Charity says, I agree that outreach and vaccine hesitancy are huge issues. However, I feel like we need to make the decisions we were tasked with first, priority groups for 1B, 1C, and 2. Sean agrees with Charity, saying we need to remain very focused with the limited time left to us. And Leslie says, I agree with Marin in part. We also need to prioritize the populations who are at risk for serious COVID illness should they contract COVID.
So that leaves us with where we want to begin. I'm hearing a couple of different things with following the data, working there first, and then prioritizing. I think there was a couple points about staying focused within the prioritization of this piece for 1B, 1C, and 2. Do folks want to, at this point, look at, I'm trying to look at this information and think about where are some of these groups being captured in other places, thinking about some of that intersectionality that was mentioned by our health advisors. Would that be a place that folks want to go, or what are your thoughts on, I think Marin, you had the point about kind of focusing on the data first, and then there was several folks in the VAC that agreed with that. Is that a place that folks want to start? I know that the piece also, I want to acknowledge that Kelly, again, wanting to share that we need to kind of center our work in and around remembering and thinking about the tribes within the state as well.
I would agree. I mean, if we're not going to solve every single problem, I guarantee you we're not. I mean, given time is limited and given there's urgency, we have to go with data so far in terms of priority. And so to me, that's driven my analysis, my decisions based upon who's getting COVID the most. And then also I do agree who has the vulnerability of getting sick or dying from COVID. But let's start moving forward on having something within that priority, and we can define that quickly, that priority within that group. So can we talk about that in terms of priorities within that group this group, I guess, I'm sorry. Yes.
Yes.
Kristen, would you drop your screen and I'll pull mine up? Which is, to clarify, this written in a less pretty way.
So you can edit.
Yeah. Thank you, Shami. Thank you for that framing.
So perhaps is there a way to kind of tackle some of the pieces that the data that we do have, right? Specifically around maybe even that first one for Black, African American, Hispanic, Latinx, tribal, indigenous, and urban native Pacific Islander.
What I would offer here, I think there's a couple of different ways for us to talk about data, just kind of to take us back to what we discussed at the top of the meeting. One is in terms of prioritizing, I think is loading multiple characteristics into an analysis that would be based on a geographic location, a census tract or neighborhood, let's just say, multiple neighborhoods, and or going through these line by line and trying to prioritize either within the line, within BIPOC, for example, and or try to rank these in a number order, which I think is challenging to do, but doable. So those are a couple of different ways, just as people are thinking about priorities, that we could begin to do this.
Sean, you have your hand raised. Thank you.
Yeah, I just wanted to follow up with Rachel's comment there that another consideration might be those people who meet of this list of 6 or 7 items, whatever it is, targeting folks who meet multiple criteria within the list, leaving the list somewhat broad, but then really prioritizing either the geographic locations where we know there are significant numbers of folks on this for the distribution, which is a different way of doing a priority, because it's not putting one item above the list on the or not, but it's saying go look at data where folks on these are and send the vaccine there, and by that nature, that's where you're going to get priority folks. Another way is that when you're doing a more broad, open, less targeted distribution of vaccine, like large mass vaccination events, making them open first to people who meet 2 or more criteria of the 5 or 6 in 1B or whatever it might be, for example. So if you're a frontline a BIPOC and frontline, or chronic conditions and multi-generational home or whatever, that becomes the first priority, and it's a little easier. Obviously, people have to self-identify on these things, so you're not going to have the ability to police it at the door. I think there's a certain amount of trust that just has to happen, and with that, you have to accept a certain amount of folks that'll game the system, but that's just the reality of how it works. And I guess I know I'm taking a lot of time, but my last comment would be on a very practical sense, because I do a lot of vaccination work around the state, sending mobile teams out and trying to do very targeted work. It is extremely difficult to make sure that you use every dose with every narrowing of criteria or every stratification. So whatever we end up with for a priority scheme, I think we should be mindful that it's also the point to just make sure we get it all used, and there should be some flexibility in how that's done, because I think the lesson learned from 1A in the very early weeks is that trying to do too much in a specific order, is kind of shooting ourselves in the foot a little bit.
Thank you for those comments, Sean. In the chat, there's a couple folks who are asking, are we going to look at overlays of risks? So Hispanic and over 80 years old. That was a comment from George Zhenya. The only practical and free of legal repercussions way to do this is IMO is target neighborhood.
In my opinion.
Oh, thank you. In my opinion, is target neighborhood and distribute in neighborhoods. Only people who can be turned away are those where it is legal to do so. Lori comments, the advantage of, let me put this, I apologize again. Lori, the advantage of the strategy is that you may have access to prioritize people if there are extra doses. I second Sean's recommendation from Zhenya. Sandy, I am concerned that if we make it too complex, we will lose people and the opportunity to deliver vaccines. Delisa agreed with that comment. Several agreements from Marin, Zhenya, Ruth, Dolores, Kristen, Maria. And Safina has a concern. My concern about neighborhood and census is that the rural and frontier areas, this is difficult. This could work in more urban areas though.
So this is Muriel. Can I just make one quick comment? As we're talking about this, I'm thinking about the operational side. And I just want people to understand, I totally agree with what we're talking about. And from a public health standpoint, we're really used to going to neighborhoods and doing pods and all of that. We have to be incredibly careful with this vaccine. It is not easy to move. And it's, you know, if we take it, I think the other thing is if we take it out of our building, we can't take it back. So we have a runner who, if we're doing a pod, we have to go and get like another couple vials and things like that. So I just want people to know that it's also, we have to think about that operational side as we're thinking about this, because some of those things for the type of vaccine, if this was flu, it'd be totally simple, but it's not as simple with this vaccine.
Yeah, I agree. I think that is, as we're talking, I keep thinking, how am I going to do that? You know, but right now we're doing it. If we have extra vaccines, we'll just call and try to get those vaccines within 3 hours so that we can get that vial done. So, but I think it's hard work operationalizing it.
Thank you, Muriel and Maria, for those perspectives on just operations from a very real local standpoint.
You know, just further comment on Sean's comment, which I agree. For example, here in Marion County, we have certain tracts or areas, parts of the county that you see definitely more COVID infection. And they happen to be a lot of Latino neighborhoods, parts of the city that are predominantly, but again, these gaps in healthcare go back to before COVID. So that's where you're seeing a lot of the infection rate. So for us locally within our county, we're working with the public health department, working with people like Sean, health providers, CBOs, to make a collaborative effort to make sure that we target specifically within our communities the people that really need the vaccine based upon our data. So I think within every county, there should be a collective effort working with health providers, CBOs, with local public health departments to really make it all around encompassing to target the people that really need the help within the regions. And I do agree that it's not going to be a perfect system. There's no way. And I agree we have to be flexible as we move forward with the process, because again, things need to be, you know, adjusted as we move forward and as we go through the process. But definitely it is not easy, but definitely we need to move forward, I think, on something priority wise.
Okay, thank you, Marin. Safina or Sandy had a comment that says, I share Safina's concern about rural areas. Kalani, please, you have a comment?
Yeah, my comment is that the people who are dying are older people, and you know, mostly beyond that, it's, at least in my experience, people from minority communities with underlying medical conditions. And then the other big risk categories are people with organ transplants or who are immunosuppressed. I think we should really start thinking about those groups and the chronic conditions. And the point about chronic conditions is that chronic medical conditions such as diabetes, kidney failure, cancer, those are all more common in minority communities. And so if we think about how would we serve our communities, you know, from I think it sort of ties into chronic conditions as well. It's another surrogate of the disproportionate healthcare problems in this country. And so I think if we can maybe center some of these chronic conditions, we'll start to vaccinate the most at-risk people within each of our communities. That's my comment.
Thank you, Kalani. So what you're saying is that it may capture some folks in various categories as well.
Yes, right. Like if I was in charge of the world, honestly, I'm a healthcare provider. I would have probably vaccinated the older people first, and then the people with chronic conditions before me. You know, why? Healthcare providers have PPE, right? We have protections. Now, I'm not saying that we shouldn't vaccinate the frontline healthcare workers. It's absolutely not what I'm saying. I'm just saying that from a Native Hawaiian and Pacific Islander standpoint, that would have probably been the way that we would have vaccinated people, or those people who are at highest risk. So I think we should center this discussion again around who's at highest risk, and recognizing that if we look at it from a chronic condition standpoint, we're going to start targeting the people within our communities who are at highest risk.
And if you, at any point, if someone would like me to edit the document to say something and I'm not capturing it already, please do. I want this document to reflect your intent. So please unmute and instruct me on what you'd like to edit.
Yeah, just a very quick question, because I thought that Kalani was making good points, but it looks like the chronic diseases, some of which he was listing, ended up being put under adults 16 to 64. And I thought the point of entry of this was that oftentimes it's people that are minority, elderly, and have chronic conditions. Did I misunderstand, Kalani?
Well, I think the people on this call are trying to help their communities, and if we think about the highest risk within our communities, it's these people with these chronic conditions, which tend to be more common in these communities because of the healthcare disparities that are experienced in this country.
But I would like, and maybe hopefully it's not too controversial a thing to voice, but I do think, Kalani, or Dr. Raphael, if you could explain. I mean, I did hear you say, and I actually agree with you, that a person who has one of these chronic conditions, regardless of their ethnicity, should go above healthier people coming from these ethnicities. Is this not what you're suggesting?
I think in the ideal world, just given how we have to prioritize, if I was to choose a Pacific Islander, age 50, with diabetes versus the same person without diabetes, I would prioritize the person with diabetes.
That is clearly the case. But can I pose the question of whether a non-Pacific Islander, age 50 with diabetes, should or should not be prioritized over a healthy Pacific Islander?
Could you give me that scenario again?
So a person, let's just say, a white person with an organ transplant who is age 16 to 64, as compared to a member of the BIPOC community who does not have chronic conditions in the same age group. Is there not an implied priority based on what we know about who gets sick and dies from this?
Can I say something about this? I'm sorry.
Well, should I maybe? From my perspective, I mean, obviously everyone should get the vaccine. I mean, you could definitely ask other questions about that 50-year-old Pacific Islander. Does that person live with someone who's 75? You know, these questions are so complicated, but from a medical standpoint, if all other things were equal, I would vaccinate the person with the transplant first, because they're immunosuppressed and they're at higher risk for getting infection and or losing their transplant, which is very, very important to them.
I'm going to pause for a second. Muse, I'm going to have you ask your question, and then I'd like us to kind of refocus and go back to some of the pieces that folks have suggested to look at this as a specific place to start. So Muse, and then we'll head back to this for a second.
Thank you very much. The question she asked is that two people, considering they have the same underlying health problems, yes, they're equal in getting infected by the disease and getting dying for it. But the question also is that one lives in a community that's high rate of infection. The chances of that one person getting disease is much higher. So that's where I see the priority should come. Not that I'm valuing one life over the other, but just in itself, this community. One thing also did not mention is this community also works in a hospitality business a lot, and that also increased the chance of taking the infection to other communities as well. So that's why priority of this people that have a higher data of infection should come first. Thank you.
Thank you, Muse. We have roughly 15 minutes before we need to wrap up for today's work. I'd like to move forward and ask folks if you know, we could do it in a couple ways. I think I know Kara had put in some information specific to chronic conditions within the chat. There's a link there listing out CDC's, I believe, definition of chronic conditions. I know there's concerns all throughout the chat about different variables to this. How would folks like to move forward? As do we want to go ahead and look at adults 16 to 64 with chronic conditions, and for the sake of the work, do we want to put that first and then move, you know, continue to move and then start looking at piecing out, you know, that works, that doesn't work, that captures other pieces? How do folks feel about that? How do folks feel about that? If I were to say what I'm hearing from the VAC at this point, at this juncture, if we move that third bullet, Jamila, first, again, if we're talking about sequencing and we know this is a large group, if we move that group first on the list, do we feel comfortable that that will capture some of where the sentiment of this group and this group's work, and where we want to center our work and our decisions? Does that feel like it's capturing at least where we're at right now at this juncture?
I would say that if we prioritize that first, we should add that there would be a special effort to reach out to the BIPOC communities within that group to make sure that we are reaching them, but I would have it broadly for all people with chronic conditions, but with a special outreach effort.
And I agree with both of these comments strongly.
Okay.
I don't agree with removing BIPOC as the first priority. And I don't. I think it whitewashes the structural racism and systemic racism that we are trying to center. I think it goes against what we've already agreed to in terms of our definition and commitment.
Yeah, I agree.
Okay. Thank you, Kelly. Thank you, Maria.
I don't mean to minimize the importance in the BIPOC community. My point is that chronic health conditions are more common in minority communities, and this way does sort of target the most vulnerable people within our communities, and it is one approach to this very, very complicated problem.
I just want to follow up. I agree with you, Dr. Raphael, but history shows that our efforts to center BIPOC people in our equity work is not always upheld. I think that by centering on BIPOC people and then including the chronic conditions, where there's an overlap there that was spoken about in the initial stages of this call today. I think we
Kelly, I agree with you, because many BIPOC communities are suffering in silence. They don't seek the help. They have so many diseases, but they never get the help. And that's a big group that we're missing. So I think by pointing them BIPOC, you tackle that problem also.
Yes.
I really do believe that.
You tackle both.
Yeah.
Yeah.
I concur with that. I concur with it wholeheartedly.
Okay. I appreciate what you raised. And I also want to just acknowledge that, we're also dealing with our own conditioning of white supremacy as it's showing up in our decision-making and our discussion. And so that is another reason to center on BIPOC folk, is that our practice of understanding the ways in which white supremacy shows up is not something that everyone engages with. We have an opportunity to center BIPOC folk and to demonstrate an equity that decenters whiteness and white supremacy.
Yeah, I totally agree. The last meeting, we spent a lot of time having a data-informed reason to, there's a equity-informed reason, a decolonization-informed reason, and a data-informed reason to center BIPOC people, and we can subset chronic conditions. The piece that I'm still confused about is the I'm not understanding the legality around not centering BIPOC and going around it. And I'm concerned with that as being a reason to not do it, because I think from a data informed perspective, we should center BIPOC, and for all the reasons that Kelly said too.
Okay, I'm gonna pause for a second. I want to thank you so much for all those comments. I want to go back to the chat real quickly because I want to acknowledge some of the things that have been said there. So I apologize if I'm kind of jumping in at a delayed time with the chat. I'm going to start with Leslie's comment. Says I meant the screen is being shared. Oh, sorry.
New, I think we missed a couple points before that, which might be important to contextualize, because Dr. Dildalao, for example, said that we need to remember structural racism is holistic. It causes high rates of chronic conditions in BIPOC, but other conditions complicate that, such as lack of access to care. And that's important because there's a very real risk of underdiagnosis in people who are not accessing care. Just like something to think about, I guess, like as in who gets diagnosed with chronic illness and who's not, but might be living with one. That's how I read that statement.
Okay. Yeah, it looks like Dolores agrees with Dr. Dildalao. Marin says these communities are being impacted now because of health disparities that have existed for a long time. The pandemic didn't create these problems. Our health system was built for white males from a historical perspective. Leslie says, I'm concerned about the particularly listing chronic conditions unless we include including but not limited to language. There are rare conditions that put people at extreme risk for COVID illness. We don't want to limit access to people with rare conditions who really need access to the vaccine. To which Kelly says, this is an issue of structural racism and the lasting impacts of colonialism as the determinants that existed before COVID. And what we want to address is our centering on BIPOC and the data as a pathway or framing for equity. Kristen, I move to recommend individuals with chronic conditions be the next priority group. Let's look at the data from chronic conditions that need to be included. Zhenya, I think so. I agree. Muriel, agree. Zenya, agree. Data support that this group will disproportionately increase BIPOC people. Dr. Dildalao, where is the data you're talking about? George, are we trying to pinpoint highest risk individuals which might require points of indexing approach or defining communities, including locales most at risk, and insist they be more effective or earlier served or both? Sue, I agree with Kelly. Dr. Dildalao, so maybe prioritizing within the BIPOC, those with chronic conditions. Zenya, I agree with Dr. Raphael. Christine, you have a question or statement? I want to pause there for you.
Yes, I do, if I may.
Please.
I'm trying more to focus this session and just listen without an opinion because there's so many. But I want to speak to both of these issues as a recipient of both issues. I am a transplant recipient, and I also am African American for those who can't see me by screen. The one thing I've heard in this whole conversation is you're assuming that BIPOC people want to be vaccinated. We're talking as if we are all lined up just waiting to be vaccinated, and we're not. So somewhere in this context of conversation, it might not be our responsibility as the VAC committee, but it is responsibility of OHA or others to find ways that we can educate. I can only speak for my community. I can't speak for other BIPOC community because I'm not a member, and reading your history does not suffice. As African Americans, we need more education on what the vaccine is about, how it affects me, my family, before there's the assumption that BIPOC people even want to partake in this vaccine. So that's just my question that I just want to point out to the numerous doctors that are there. We can't skip that crucial key piece. And then the last point I want to make is, as an educated African-American woman, I have my master's and I'm getting my licensed in social work. And I'm pointing this out because there are few educated African American women. There are few educated African American men. So I have educated myself on this information, and I know this is important for me, but we're talking about the working poor. We're talking about low income people, and we're talking about people whose education level may not be at a high standard. So again, we're communicating about communities as if this language is easily understood to them, and it is not.
Thank you so much, Christine, for bringing up those various points. And you touched on something that I wanted to mention quickly too, is that indeed your comment about BIPOC communities and not necessarily ready to line up to take the vaccine is well taken. OHA staff, the community engagement team, have been doing listening sessions across the state with various specific communities, and what you're bringing up is something that they've also been hearing in their listening sessions. So thank you for that. I think that's a very important piece to the discussion. I do want to acknowledge that we have about 5 minutes left into this, and I know I did not get to all of the comments and messages today. I apologize for that. I will work to get that a little more smoother. I would propose at this point that we take a look at these pieces. What I'm hearing is that there's the balance of the first two. If we're going to concentrate on these first two at this point, one, leaving BIPOC, specifically the 4 groups that we were identified within this group, also potentially breaking down those pieces within categories itself, and then putting in adults 16 to 64 with chronic conditions as the next group. So I'm hearing that we're kind of landing right there at this time based on agreement, agreement and disagreement, really, but more so that the group wants to move forward in acknowledging the breakdown of inequalities and systemic racism within how we choose, I don't want to say choose, but within how we do this sequencing. So if it is okay with this group, my gut is saying to me in this next few minutes, if we can agree that this is where we're just going to land today, that we will keep it at BIPOC and then the next group being adults 16 to 64. And we will revisit this next week when we gather on Thursday.
Yeah, and can we look at the chronic conditions? Because I think there's a lot more than that.
Yes.
Because there's COPD, there's asthma, all this other stuff that affect, get affected by COVID.
Yes.
And this is Muriel. I would agree with that too. And the only thing, and I think I put it in the chat, was for some of the smaller counties, I want it that at least it's concurrent, because we have, I mean, the eastern part of the state, there's small populations of some of these groups, and I don't want it to, I want to be able to move through the groups, but at the same time, focus on that group first, but be able to do it concurrently.
Yeah, and what I'm also hearing from this group is that we want to be nimble, right? We don't want to make it so stringent in that for operational purposes, people don't, there's not this lag. We want to get shots in arms as much as possible. And then also, Christine, I see that your hand is raised, so I want to go ahead and please. And then Dr. Derek, and then Leslie. Christine?
That was an accident, sorry.
Okay, no problem. Derek, please.
Yeah, sure. Thank you. There's just one thing that I'd like to say, and I'm not sure it's necessarily something that we can do here, but I think it needs to be said. And that's given, we're here to talk about vaccinations in order to help people and to stem the spread of the disease. We have a shortage of vaccine, and I'm very concerned that there are not other discussions around supporting efforts to mitigate the spread of COVID-19. And in the face of decrease of vaccination or vaccine numbers, the as was mentioned by Christine, the hesitancy to be vaccinated in certain communities, as well as mutations in the virus, the increased transmission rate, potential mutations that may decrease the effectiveness of the vaccine, that there needs to be other discussions about ways to mitigate the impact of the virus. And we see in other countries, such as in Taiwan, we see in Germany, the increased use of more effective masks and the dispersal or the spread of or access to these masks across the population. So I think that, you know, in the vein of what we're trying to do here, and that's to help people and save lives, we need to have other discussions about ways to impact the spread of the disease. Because not everyone's going to get a vaccine. And those people who may be able to get a vaccine are going to be limited. We're triaging, and we need to help those people also who aren't going to be able to get it. Thank you.
Thank you, Derek. I'm going to ask Leslie to go next.
Thanks. I'll be brief. I wanted to agree with Dr. Raphael about the chronic conditions list, but I also want to combine a couple things that Christine was also talking about. People need to be able to recognize where they fit on this list. And one of my concerns is that if we say adults with chronic conditions and then list out conditions, we could leave a really rare one out, as I said in my previous comment. But also, if we say chronic conditions, we need to be clear what that means for people so that they can easily identify, oh, I fit in that category. And the reason this is so important is I know that there are people currently in the physical disability community who are actually in phase 1A, but yet don't see where they fit clearly in the OHA phase 1A guidance. And I think that's a big lesson for us to learn from here, is that when OHA is putting out a list of the priorities, that we need to be able to be talking with communities and making sure that that information is using words and phrases that different communities will recognize themselves in. So I just want to make sure, I think that that applies to a lot of what we're talking about today, but I really need to make sure that we don't have a hard list of people under the chronic conditions, because there are people that honestly have been in their homes now for a year that have conditions that put them at very high risk of COVID and are not listed on that list. And they're never going to be. It's a super rare thing. So those are my 2 comments for the day. Thank you.
Thank you, Leslie. We are at that point of the 12 o'clock hour. I know lots of folks have to come off at this time. So I know that some folks were asking about whether we're going to move to a vote or a consensus about these 2. Again, I would like to ask folks to hold on to these 2 as placeholders. We have not agreed that these are what moves forward, but we will make a decision next week, Thursday, on these 2 and the rest of it.
And
So
if I could offer
please.
what we could do with folks with these conversations. There are a number of conversations, these 2, and there are other things. We could go back and work on a variety of different scenarios and ways to implement these. I think the top 2, I've really appreciated the discussion, and I'm also thinking about how to implement. And I think there's both policies as well as allocation, distribution, communication, all the things that you all talked about. So if folks would be comfortable with that and give us some grace in terms of processing this around and coming back to the group with some ways to try to meet your intentions around these, I think that could be helpful.
Yeah, thank you so much for that, Rachel. And thank you. I know that we are at the new and hour past that. And so thank you. We will resume with the optional meeting on Tuesday. That will give you some, we have some folks lined up from the community engagement team to talk to you about some of the listening sessions that have been happening around the state. And then next week, Thursday, we will continue with the prioritizing and the sequencing of the groups within our recommendations. Thank you so much, everyone, for your hard work and your participation today. So appreciative.
Thank you. Bye-bye, everybody.
Thank you.
Have a great day,
Jamila.
everyone.
Oh, Jamila, can you capture everything in the chat for me? I don't want to miss. Is that possible?
It's not giving me the option.